Good afternoon and welcome to today's episode of the ESDR Kitchen. As you know, the ESDR Kitchen is a webinar series that has been launched now a couple of years ago and has 4 different tracks. So today's episode belongs to the recipe book. It's my great pleasure to chair this episode. My name is Enikö and I am a professor of dermatology at Uppsala University in Sweden, and I'm happy to chair this episode together with Anna Balato from Naples, who is also an ESDR board member. So, as I said, today's episode is a recipe book and it's supported by Bristol Myers Squibb, so we thank them for their generous support. So in the recipe book, we usually can hear about different techniques that are of interest for skin research that can be utilized in skin research. And today's speaker is Professor Ryan Donnelly, who is not a skin researcher, but he has worked with a technology which can have a great interest in skin research, which can have a utility in skin research, microneedle systems. So Professor Ryan Donnelly is a chair in pharmaceutical technology at the School of Pharmacy at Queen's University Belfast, where he's director of research. He's a pharmacist, and his research is centered on polymeric drug delivery systems for transdermal and intradermal drug delivery. And he has, as I mentioned, he has worked on novel microneedle technologies. He's author of over 1,000 publications. He has 11 patent applications, and he has a large research group of approximately 50 people. And he has received many different awards. I will not make a list of them because I would not like to steal the time from the lecture. We are very much excited to hear about how we could use microneedle systems in skin research. So please, Professor Ryan Donnelly, the stage is yours.
Thank you very much, Enikö, and thank you very much to ESDR for inviting me to speak. It's a real pleasure to have this opportunity. So hopefully everybody can see my screen. And I am going to talk to you today about microneedles and their particular applications in skin, rather than systemic drug or vaccine delivery, and how some new developments could potentially be of interest in dermatology. So I'm going to start off introducing you to microneedles for those who aren't familiar. I'll talk about some historical research and applications of the technology, and I will then talk about the commercial medical device and cosmeceutical products that are out there at present. But I think we can change our mindset to consider delivery of drug substances to have a beneficial effect for patients. To do that, we need to take into account patient factors, and we need to work out how we are going to have a strategy to take our product right through to the market. So what you can see here on this screen are examples of microneedles. So the spinning image shows an optical coherence tomography scan of the skin of one of the PhD students in the lab, where microneedles have been inserted into their skin. So microneedles tend to be less than 1 millimeter in height. They can be made from various different materials, from elemental silicon to polymer to glass to metal. But what they all have in common is that they painlessly and without drawing blood penetrate the skin stratum corneum barrier. And this opens up aqueous pores and means that things that ordinarily would not penetrate the skin after topical application can now be delivered to the viable skin, the epidermis and the dermis. Now, the idea was first conceived in the 1970s, but it took another nearly 30 years for the first paper to be published. And to date, microneedles have been extensively studied for vaccine delivery because, as you will probably know, the skin is full of professional antigen presenting cells. So it's a rich site for vaccination. But there have also been a number of technologies developed for cosmeceutical use. If we look at clinicaltrials.gov, what we'll see is that there are well over 100 international clinical trials currently listed, and most of these are for delivery of vaccines. But we also have trial study in biologics, cosmeceutical applications, looking at immunotherapies, diagnostic agents, applications in photodynamic therapy, and then applications in diagnosis or monitoring where we're extracting something from the skin and using that to assess a condition or patient's general health. So a lot of hope was placed on Zasano, the company that had coated microneedles, getting the first FDA approved product. But for various reasons, that product did not receive FDA approval, and Zasano aren't really a going concern anymore. There was also a study done by Radius Health that looked at abaloparatide, which is a parathyroid hormone analog, and they compared that against subcutaneous injection. While both were effective in maintenance of postmenopausal bone density in the hip, the injection performed slightly better. There have been a number of clinical trials conducted by the Australian company Vaxas, looking at influenza and COVID-19 vaccines being delivered. But what I would wonder is, are coated microneedles really the best approach overall? Microneedles are very small, and so the loading capacity is not going to be high. It can be challenging to coat such tiny structures accurately, and application can be challenging. What if the coating actually comes off during the application if it's dried out too much? So we need to think about what alternatives might we have. Well, VaxS, that's based in the US, a different company from Vaxas, uses controlled release silk materials to sustain the release of vaccines in the skin after the microneedles have essentially dissolved in the viable skin layers. And they've looked at influenza, including using RNA vaccine products in that case in collaboration with AstraZeneca. And then we have the company that's probably the furthest advanced in the vaccine space, Micron Biomedical from Atlanta in Georgia in the United States. And they use dissolving polymeric materials, and they've shown really positive phase 1-2 results with measles and rubella vaccination. And they now have a manufacturing deal with LTS Lomond to scale up manufacture for phase 3 clinical trials. And that's being funded by the Bill and Melinda Gates Foundation. But microneedles have been commercialized for cosmeceutical use. So if we consider a product called the Derma Roller, titanium needles up to 1.5 millimeters are mounted on a cylindrical drum, and this is repeatedly rolled across the skin. So essentially what you're doing is you're insulting the viable skin layers multiple times. And this tends to cause a healing response. And that stimulates blood flow and collagen production. And it's been shown very clearly to improve stretch marks, acne scars, and wrinkles. But it has unfortunately been used as a pre-treatment prior to topical application of cosmeceutical formulations that were really designed for application to intact skin. So not only would you see enhanced delivery of the active ingredients in an anti-aging skin cream, for example, but the excipients are also able to penetrate into the viable skin layers, even though they were never intended to reach the viable skin in those numbers. And topical skin products aren't made as sterile products. So you could have microorganisms actually penetrating into the viable skin that would ordinarily not penetrate there. So a note of caution there. We then have the microhyala products. So these are dissolving hyaluronic acid microneedles. There are various different shapes and sizes of patches, and the idea is that they penetrate the skin and they deposit hyaluronic acid in the viable skin layers. This has been widely marketed for at-home use, but I haven't seen any scientific evidence that shows the anti-aging effect of the product as yet. We have got our hands on these microneedles, and they do penetrate the skin, but we haven't seen scientific papers showing the effectiveness of these. The idea with hyaluronic acid, pardon me, is that it would swell in the skin to plump up the skin and make fine lines and wrinkles appear less obvious, and that collagen could be produced from the hyaluronic acid. So essentially it could help to remodel the skin on a longer term basis. But I think that there are a lot of other considerations beyond cosmeceutical delivery. So we may wish to deliver drug substances into the skin to enhance treatment of skin infections or diseases like psoriasis or eczema, for example, or even for non-melanoma skin cancers. So some things we need to think about. The first thing is that microneedles create aqueous pores in the skin. So we need to think about the drug properties. If our drug is very poorly soluble, how do we actually use the microneedles to deliver that drug? And how do we avoid excessive systemic delivery? Because about a third of the blood in the body is flowing through the skin at any one time. And if we want just a local effect, how do we avoid systemic administration? And then we need to think, what would we actually use this for? And if it was going to be used repeatedly, what might happen to the skin or to the patient in general? And can we make microneedles at a reasonable cost? I actually think we can overcome these difficulties, and that will really create considerable benefits from any company commercializing microneedles and will also lead to considerable benefits for patients. So the first drug we looked at more than 10 years ago now was the photosensitizer precursor 5-aminolevulinic acid. So this is normally used in management of non-melanoma skin cancers, where topical application in a cream causes accumulation of protoporphyrin 9 in rapidly developing cells, and then irradiation with red light generates singlet oxygen, which destroys those cells selectively, and then the skin heals up without scarring. So we wanted to see, could we improve delivery by pre-treating the skin of a mouse with silicone microneedles and then applying a patch containing 5-aminolevulinic acid. And what we saw was we got about a twofold increase in ALA, as it's called, penetration into the mouse skin. And we saw a much more even distribution of protoporphyrin 9 than whenever we actually looked at the fluorescent images in the mouse in vivo. But ALA penetration into skin lesions is reasonably good, and it certainly is effective. But we wanted to see, could we look at some other compounds that wouldn't ordinarily penetrate the skin very well? And so we used a preformed photosensitizer. So this porphyrin compound that is a molecular weight of about 1400 Daltons. It was actually quite hydrophilic, and we found that there was virtually no penetration without the microneedle pre-treatment. But whenever we pre-treated with the microneedles, we got a 45-fold increase in delivery. And as you can see from the bottom image with the mouse, we really got a very consistent fluorescence. So the idea here is that you wouldn't have to wait for photosensitizer to be generated in the skin lesion. Deliver the photosensitizer as a preformed compound by pre-treating the skin and then applying a microneedle patch. And this could be useful where deeper skin lesions are difficult to treat with topical ALA or methyl ALA, and systemic administration of a preformed photosensitizer would cause prolonged widespread cutaneous photosensitization such that the person couldn't go outside without getting a sunburn. So this could be useful, but one thing that really struck me was pre-treating the skin with microneedles wasn't ideal. It would be better if the drug was built into the microneedles, and we would have a one-step application in that case. And so what we did was we loaded some hydrophobic photosensitizing compounds into nanoparticles, and then we put them into dissolving microneedles. We applied them to the skin, and then as you can see in the little image below, the microneedles dissolved and deposited the photosensitizer in the skin. And whenever we took the skin and we sliced it up, we could see photosensitizer right down to 1.5 millimeters in the skin. So dissolving microneedles have quite a bit of promise to delivering compounds, both hydrophilic and hydrophobic, into the viable skin layers. So we then thought, well, what medical conditions might this be useful for? And we came across cutaneous leishmaniasis, which is caused by a bite by a sand fly and can cause very disfiguring skin lesions that ordinarily have to be treated by injection into the the skin lesion itself, which is very unpleasant for the patient. So we thought if we took amphotericin B, which is active against leishmaniasis, and put that into the microneedles, then there would be a local antimicrobial effect, but because the drug is so hydrophobic, it wouldn't go elsewhere in the body. And this is really important because amphotericin B is so hydrophobic, it normally has to be given by a liposomal intravenous injection. And it then goes everywhere in the body and can cause liver and kidney toxicity. So we put nanocrystals of the drug, so basically ground the particles of the drug into very small crystals, put them into dissolving microneedles, and then we did a quick microbiology study to show that it would kill fungi, which are just a model microorganism. And you can see the zone of inhibition around the microneedles here, but not in the controls. And then we applied them to the skin, and you can see the yellow deposition of the drug. And then when we went to a mouse model and we compared the amphotericin B microneedles, that's the dissolving microneedle patch, with IV administration, then we got a very high level in the skin that actually persisted for a full week. Whereas with the IV administration, the amount in the skin was minimal. But this trend reversed when we sacrificed the animals at different times over the week. And what we found was with the microneedles, we got very little drug in the plasma and we saw very small amounts in the organs. So delivering a potent molecule directly to the site of application on a skin lesion using microneedles could be beneficial in terms of prolonging the drug content there, especially if the drug is poorly soluble, without delivering the drug to the rest of the body. And those microneedles will dissolve in the skin within about 15 minutes. So we then thought about, what about other compounds? So we looked at acyclovir, which was a bit more water soluble, and we wanted to see, could we deliver that into the skin and could we keep it in the skin? So what we found was whenever we looked at the amounts in the skin, the dissolving microneedles loaded with acyclovir delivered a lot more drug, and that was actually maintained for 48 hours after a single microneedle application. But with acyclovir being more water soluble than amphotericin B, we also saw the drug actually entering the systemic circulation as well. So if you've got a small molecule drug and it's not very hydrophobic, then there's a chance that you will also deliver the drug to the systemic circulation. But we have looked at a number of other compounds, so salicylic acid, calcipotriol, and dexamethasone, that could all be useful in the skin. And with calcipotriol and dexamethasone, we were able to keep them at the actual application site. Salicylic acid is a little bit more water soluble, and so it will move away from the application site and has the potential for systemic absorption to a greater extent of these two more insoluble compounds. So what's been clear for local application of drugs using microneedles, the drug water solubility and also the particle size for more hydrophobic compounds will be important in terms of, do you just get local delivery or do you also get systemic administration, which may be in some cases undesirable. The skin can also be used as a pathway, and I mentioned vaccination at the very beginning, and the skin is full of dendritic cells and Langerhans cells that are professional antigen presenting cells. And if you deposit a vaccine in the skin, not only can you get a potent systemic immune response, but you can also get an immunoglobulin A response at distant mucosal sites, because essentially the viable skin layers think that they're a mucosal surface. So if you vaccinate intradermally using microneedles, you'll also get this secretory immunoglobulin A immune response in the mouth, in the airways, the lungs, and the reproductive tract and the anus as well. So we took some PLGA nanoparticles loaded with ovalbumin as a model vaccine, and we also put some rhodamine in there so we could see it. And you can see the microneedles that had dissolved and deposited the particles in the skin of the mouse ear, and the particles were taken up by cells. You can see we've stained the nucleus of the cells with DAPI after we extracted them from the sacrificed animals. You can see that the cells have taken up the nanoparticles. And whenever we challenged the animals with a Sendai virus that expressed ova peptide, we saw that the vaccinated animals got sick but then recovered, but those with the blank nanoparticles denoted by BNP didn't actually recover and they had to be sacrificed. And there was a big difference between not vaccinated and vaccinated animals in terms of lung histology. And if you use a B16 ova melanoma to challenge the vaccinated animals, you can see that there's no tumor growth, whereas in the unvaccinated animals with the blank nanoparticles, the tumor continued to grow. And there's a big difference between the tumor sizes here between the vaccinated and unvaccinated animals. So the skin can be very useful as a platform for vaccination. And then with dissolving microneedles, because they're a dry state formulation, you also have the benefit of enhanced cold chain free stability and also ease of application by people who aren't skilled healthcare workers. And since the microneedles dissolve in the skin, you don't have a contaminated sharp to dispose of. So this could be really useful in developing countries in particular. And then we have lymphatic filariasis, which is not a skin disease, but it actually affects the skin and tissues of people in a big way. So basically, again, people are bitten by an insect and you then get a parasite that has in its gut a bacteria that causes damage to the lymphatic vessels. And this causes disabling and disfiguring swelling of the limbs. And about 120 million people are infected, with about 40 million of those disfigured and incapacitated by the disease due to the damage to the lymphatic vessels. Oral anthelmintics and antibiotics will treat the bacteria and the parasite in the blood, but not in the lymph because they penetrate the lymph poorly. So there's clearly a role for a better treatment here. And what's known is that the skin layers contain a much higher density of lymphatic vessels than the intramuscular space, for example. And also the hydrodynamic pressure in the skin is high. So if you could deposit these drugs in the skin, particularly if you can use particles less than 100 nanometers to allow efficient lymphatic uptake, then you may be able to prevent this disfigurement caused by the disease. So what we did was we took solid lipid nanoparticles loaded with either antibiotic or anthelmintic drugs. We applied them to the skin of rats, and then we sacrificed the animals at different times, and we took the lymphatic vessels and we quantified the drug and compared that to the data from animals where we had given the drug orally. And what we found was for the antibiotic doxycycline and the anthelmintics, diethylcarbamazine and albendazole sulfoxide, we had about a 7-fold increase in the lymphatic levels of these drugs compared to the same drugs given orally. For albendazole sulfone, the trend reversed, and this was because this drug is formed during first pass metabolism through the liver, and so that's why the trend reversed there. But I think this is highly promising that we can deposit particles in the skin specifically designed to go to the lymphatic vessels, and we can have a much greater drug content there. And this may also be useful in autoimmune diseases, and it may be useful in targeting the lymphatic reservoir in HIV. So I think that there's a lot of promise here, but there's things we need to think about if patients are going to benefit. So microneedles have been around for a long time, but we don't have a product for drug or vaccine delivery yet. There are some hollow microneedles for intradermal injection and cosmetic products, but we really need to think about what do we deliver. What about the microbiological status of the microneedles? What might regulators say, and how will patients use the system? And also, how do we scale up the manufacture to useful levels? So very often a skin lesion will not be on a little 1 square centimeter area like would be useful for a vaccine patch. So what we did was we took a small patch and we took a patch that was 16 square centimeters made up of 16 small patches, and we got people to apply them to their own skin after reading a patient information leaflet. And then we measured the depth of insertion of the microneedles and the width of the pore created using optical coherence tomography. And what we found was that people could apply the large patches just as well as the small patches. And we looked at the large patch at various different points, and the insertion depth of the needles was not statistically different from the small patches. So large patches could be applied, and that could allow us to treat larger lesions. In terms of safety, what we found with dissolving microneedles was that there was no measurable microbial content in there. And even when we deliberately spiked the gels we used to make the microneedles with microorganisms, none survived. When we measured endotoxins, they were below all pharmacopoeia limits. And whenever we penetrated the skin with microneedles and then seeded on the surface of the skin radio-labeled microorganisms, we found that there was significantly lower penetration of microorganisms through the holes in the skin compared to a single hypodermic syringe puncture, even though the microneedles made a greater area of holes in the skin. And this has been shown in all clinical studies that I've read, that microneedles have not shown any likelihood to cause skin infection or systemic infection. So we took a study then on where we arranged for a series of new but fully immunocompetent mice, and we applied microneedles to their skin once a week for 5 weeks. And at the end of the 5 weeks, we found that the skin appearance was unchanged relative to control. There was no evidence of polymer building up in the skin of the mice, even though the microneedles were dissolving in the skin. And when we measured transepidermal water loss at the end of the study, it wasn't changed significantly from what the barrier function was at the start. And then when we looked at immune response to see were we essentially vaccinating the animals against the microneedles themselves, it didn't seem to matter what polymer we used, whether it was Gantrez S97, PVP 58 kilodaltons, or a swellable hydrogel material microneedle. The density of the microneedles weren't important, and it didn't seem to matter whether it was male or female animals. There was no measurable increase in immunoglobulin G relative to control. And it didn't matter whether the microneedles dissolved in the skin, as in the case of Gantrez or PVP, or the hydrogel forming microneedles that were removed intact from the skin. And then we measured interleukin-1 alpha as a measure of inflammation, and we found that there was no measurable increase relative to control, and that needle density had no detectable effect, and even the low pH of the Gantrez formulation had no significant impact. So this is all very promising. We also looked at the risk of infection, and we found no measurable increase in C-reactive protein, which is typically elevated in infection relative to control. There were no increases in body temperature, and the animal weights didn't change significantly. So I think this shows that repeated application of microneedles is unlikely to cause any problems. We've since done some studies with the hydrogel forming microneedles in human volunteers, where microneedles were applied every day for a week, and we didn't see any significant changes in biomarkers or skin barrier function. So I think that the way forward for microneedles is now becoming clearer. So LTS Lohmann in Germany have Europe's first GMP manufacturing license for microneedles, and they will make the products for Micron Biomedical for their phase 3 trial. They're also making microneedles for 2 clinical trials that companies are doing on technologies that they have licensed from our lab here. And I think polymeric microneedles create a series of unique possibilities in terms of delivery into the skin. And this gives us the potential to address a range of dermatological challenges. We're seeing a lot of investment now from big pharma companies, both in the skin and also systemic delivery side. And the PATH Center of Excellence for Microarray Patches is bringing together experts from industry, academia, the pharmacopoeia, and the regulators to help microneedles to move forward by identifying critical quality attributes and also quality control tests that could be used. Our own lab has a big program from the UK's Engineering and Physical Sciences Research Council, and in that we are showing the safety of microneedles for long-term use using mini pigs, which are a common model for dermatological products. As I mentioned, our work is going to clinical trial for systemic drug delivery in the new year. And I think that now more than ever, we are poised to finally have a drug or vaccine product based on microneedles commercialized. And I think then that will lead to further investment from industry, and we will begin to see patient benefit over the coming years. So that's a whistle-stop tour of microneedles and their uses in skin. I would like to thank the sponsors of our work and all of the people in the lab who do the work on a daily basis. And of course, I'd like to thank ESDR again for the opportunity to speak, and to you for your attention. Thank you.
Congratulations, Brian, for this very interesting and fascinating talk. I will break the ice with a very quick question, practical question, because this is the recipe book. So you give the ingredients, the methods. So now a very practical question. And you showed them very interesting models in mice models. But I was wondering, when you are going to use this technique in human subjects, if you checked on differences in microneedle delivering of different drugs, depending on anatomical sites, on different body areas, the presence of air and the thickness of the skin, how much could influence the delivery?
Yeah, it's a really good point, Anna. And I think that obviously you wouldn't be developing microneedles to apply to the sole of the foot or to the eyelid, for example, because obviously the thickness of the stratum corneum is going to be very different in both cases. Similarly, you wouldn't be applying it to the belly region because there's such a difference in subcutaneous fat deposition. I think in skin conditions, it's probably going to be the limbs and maybe on the trunk or the face or the top of the head. Anywhere where there's bone underneath, you will have no problem in penetrating the skin. But if you're if you're applying microneedles to some part of the arm where there may be differences in subcutaneous fat or in muscle, then you probably will use an applicator device to stretch the skin and then apply a defined force. You can also use pressure responsive films that will change color in response to the microneedles dissolving. So we've filed a patent recently where we have used a color changing material that will only change color when the microneedles dissolve. So you basically know that you've successfully delivered the compound into the skin. And obviously, as people get older, they're more likely to need medicines, and so they probably are going to be bigger users of microneedle technology. So what we did was we asked people from the charity AgeNI to come into the School of Pharmacy, and we had ethical approval to apply microneedles to skin, and we got them to apply microneedles to their own skin and compared that to the 20-something PhD students in terms of depth of penetration. And what we found was that even though the collagen density was different in the older people, the depth of insertion was exactly the same. What we did notice, though, was the speed of recovery of barrier function was a little bit slower in older people, probably to do with less elasticity in the skin. So what you described still needs a lot of work, Anna, and I think that a clinical study for a dermatological condition will need to be really thorough in showing consistent insertion and consistent delivery in the people in the trial, so that we can be sure that if we were to get a product, that we're going to actually have something that can be reproducibly used by either a clinician in the dermatology suite in the hospital or by a patient at home.
Thank you. And
yeah,
no, go ahead.
If you allow me, I could also have a quick question. So because the examples that you mentioned were mainly very small molecules, and you mentioned it briefly that it's quite important what we deliver. So very often we face this limitation that we would very much like to deliver molecules which are not really optimal for topical delivery because they are too large or because of other chemical properties. So how do you see it? Would microneedling solve this problem or could be a partial solution to this problem?
Yeah, it could be, Enikö. So obviously I've presented a fairly small snapshot of what we do here. And we've delivered every type of compound you can possibly think of at this stage. We've been at this for 15 years. We've delivered therapeutic antibodies with molecular weights of 250 kilodaltons, large proteins, nanoparticles, poorly soluble nanocrystals, and all of those things could be delivered, especially with dissolving microneedles, because really you're just loading it into the microneedle and the needle then dissolves and your drug is in the skin. Then you're not relying on the drug diffusing through anything. And so the molecular weight actually doesn't matter. The water solubility doesn't matter. But what is interesting is how long will your molecule remain in the skin if you only really want it to be in the skin and you don't want it to go to the systemic circulation, because obviously the skin is a really good site for systemic absorption because of the rich dermal microcirculation. So basically what we would do is, if we were given a molecule and we were told that there were certain things that needed to be met in terms of a certain amount that needed to be delivered, or it needed to be retained in skin for a certain period of time, that would modify the formulation approach that we would actually take. And if you want to retain a molecule that will easily be absorbed systemically, then what you might do is you might use a more lipophilic prodrug of that compound, or you might make your microneedles from a gel that will swell and slowly dissolve in the skin and therefore control the release of your drug to maintain its presence in the skin for a little bit longer. So I think it depends on the molecule and what the clinical need is in terms of how you would formulate the system. But the beauty of dissolving microneedles is there's a lot of flexibility in terms of formulation.
Thank you. I believe there is a lot of potential there.
Thank you.
Is there a maximum size?
Yeah, what we found ourselves, Anna, was that once you go above 1 millimeter, you will feel the microneedles going into your skin. So it's like pinprick sort of pain. And you would also see little tiny bleeds underneath the skin if you go above 1 millimeter. So obviously in some cases that may be acceptable if the alternative was systemic administration or an intralesional injection. But for routine use, then I think that if you can keep the needles below 1 millimeter, then you reduce any sensation when the microneedles are applied. It only feels like a feeling of pressure.
Mm-hmm. Let me check if there are some questions from the audience.
Yeah.
No. I think we are on time. And what do you think, Enikö? Do we have time for another question, or we have to close?
I think that it's time, but if there are any questions from the audience which they didn't have time to ask or they need more time to think, then of course maybe they could approach Ryan with any questions that may arise, and yes, and the recording will also be available.
Lovely. Yeah, happy to do so. Thank you very much.
Thanks, really thanks from my part. And so now we are going to close this session. And just before to close, I would like to highlight the next episode. And we have another great speaker. So we will have Ellis Bretter, and he will talk about the personal sequence. So very curiosity title. So let's stay tuned. And another reminder that all the episodes, as Enikö has already told, all the episodes are available on YouTube, and you will receive also in the newsletter. So if you missed live today, you can see it online on YouTube. So thank you very much, Ryan, and bye.
Thank you. Bye-bye. Have a nice day.
Bye-bye. Have a nice day.